I'm Katie Doyle. I am very involved and passionate about primary care, and hopefully we'll be able to share with you about what we've done at Northwestern that really makes our program a primary care focused program for care coordination. Now, why is it important for PCPs to be the center of a care coordination program? A lot of the burden that we see in our value-based care contracts are placed on the primary care physician on prevention and wellness. And as we've seen over the past 10, 20 years, our fee-for-service models allow for our specialists to have great reimbursement for procedures and surgeries, which allows them to invest in resources to help their operations. But primary care hasn't appreciated that change or that space for the past 10 to 20 years. And now we're finding that it's harder for them to manage chronic illness, especially with multiple comorbidities. They don't have enough time in their appointments. They don't have enough teams in their clinics to help manage patients. There's infrastructure that lacks, and patients don't know what they don't know. We often have patients say, I don't need a care coordinator. I have 5 docs at Northwestern. Everyone's on the EMR. It's fine. But the truth is we know they're not talking to each other. And so that's actually a huge gap. Katie. Oh, thank you. And so we want to enhance the team-based approach, and we really think primary care is where the focus should be. In our model, I showed this yesterday, but we focus on patients and our primary care physicians at the center, and then we use our interdisciplinary team around them to support the chronic conditions and high-risk needs of our population. The right shows the contracts that we participate in, value-based care contracts. So behind the scenes, administratively, my job is to make sure we meet those requirements, we adhere to the UM plans, we are pulling levers to meet population volumes as the contracts require. But to our physicians, they feel like they just have nurses and social workers and pharmacists to help them in patient care. We will take any physician referral, no matter what, because that's how we build trust, and they will let us take care of their patients. When we used to be a very payer-centered model, our physicians would be frustrated because they would have patients that they want support on, and we would say, sorry, we can't do that. And that would actually ruin the trust and impact the engagement of working with our primary care docs. So the key is to use our program, you have to have an NMPCP, and that is our 2 large employed groups and our aligned private physicians in our clinically integrated network. Northwestern is a 10-hospital system. We have 2 large medical groups, and then, like I said, the CIN. And we span, if anybody knows the Chicago area, there's DeKalb, Kishwaukee Hospital is the furthest west, Lake Forest Hospital by Evanston, and then we are starting to penetrate the south market of Chicago slowly. So we've grown fast in a very short period of time and are looking for ways to help our physicians manage their populations better. This is kind of small, so I apologize, but to give an idea of the breadth of people that we should support in our program, what I showed you here is we have maybe 30 people, but here we have 400 to 500,000 lives that are in our at-risk contracts. We have 400 primary care physicians that we're supposed to support. I wrote 7 here, but it's really 10 hospitals, and we have to prepare for future growth. So one of the reasons why I like this conference so much is that in order for my job is to lead our program so we can meet that population, that volume, but we can only do that with technology and people. We can't just do it with people. Our CFO will never let me triple my team overnight. And so again, relationships is really important, efficiency. We want to make sure that we're keeping people in Northwestern. We think Northwestern's a great place to be. We want our patients to be there. And we focus on reliability. Yesterday, I talked about the reports we give to our staff. We're very focused on consistency and very basic standards so that when we're ready to scale and ask for more support, we have a good story to support that. This is what our team looks like. 18 months ago, it was just me supporting everybody across the whole system. And now we have 2 managers that actually oversee and build relationships through the medical groups. They work with the practices, focus with our primary care docs, and I recently just now have the privilege of leading our post-acute portfolio as well. And so what the goal is to build, the resources. I like to joke that my team's the purple car driving patients through all the purple silos of Northwestern. And we, again, are nurses and social workers. We also have pharmacy that we support or partner with. And then we have a data coordinator that helps us with patient assignment based on our own risk stratification tools. We think of our operation model in 4 spaces, right? There's outreach. So we get physician referrals, but we also look at all of those contracts. We identify which patient's at risk. We assign them to a nurse, and a nurse does a cold call out to try to enroll the patient in the program. Patients don't answer their phones. It's very frustrating. Our nurses hate it. And our outreach piece is one of our barriers in our program. Activation, these are patients that have said, yes, please work with me. I want to set goals. I want to have you call at least once a month. And we work with these patients to get them to self-management. We've been proven to have pretty good outcomes for patients in our program for at least 2 months. We've seen improvement in show rates. We've seen reduction in utilization. We've seen improvement in hemoglobin A1C. Our internal transitions are with our hospital partners. And so we work with our hospitals on populations they want support with. Now, we only help their patients that have an NMPCP. The hospitals get mad at us because they want us to help everybody, but we can only help some people. So if they have an NMPCP, we work with our hospitals. Lake Forest Hospital wants us to help them with their multi-visit patient population. Delnor Hospital wants us to help them with their COPD population. NMH wants us involved in their high-risk readmission population. And so they tell us what they want, and if a patient has a PCP in that population, that's an NMPCP, we help them with discharge home planning. And then external transitions are obviously very important. Does the patient go to a post-acute facility? Who's their community? Who's their family? We want to make sure we connect with them with the right resources to, again, get the patient to self-management. Here's our in-the-weeds operations. The benefit to primary care is that we give our patients our direct phone numbers so they don't go through the call center, which everyone gets really happy about. We love our call center, but the patient gets our direct line to the nurses for phone calls, which reduces some of the message burden in the clinics. We are taking the patients that have the higher risk, and so again, that reduces some of that message burden that physicians feel because the patient calls every day, 3 times a day, because you said I could, and I don't understand my medication plan or my next steps. So we really feel like that's a win. The docs really appreciate it. And then again, we help bridge these transitions between NM hospitals and the employee groups. It's a benefit of being part of a bigger system. We have all these connections that we can build bridges for, and our doctors really appreciate it. What I think is great is, and all of us do this work, our job is to get patients to the right care at the right place at the right time. But it's a huge paradigm shift to think of utilization as an ambulatory problem and not an inpatient problem. And we're helping change that thought process at Northwestern. So one of our responsibilities is to impact our operational need in our system, right? So we have capacity issues. We have our EDs are overburdened, and we want people to get to our immediate cares. And so our operational outcome is to make sure we impact ED utilization, admission rates, and improve show rates in the clinics. A lot of people mentioned in the conference about access to transportation. It's a huge barrier. We have a lot of work in place to help with that, and that gets patients to their appointments. And so these are our outcomes that we support, and it actually helps our primary care clinics by having patients come to their appointments and making sure transitions occur. This project, we actually just were accepted for this project for a Vizient podium presentation. Lake Forest Hospital wanted to work with us on their multi-visit patient population. Their hospital's struggling, there's a lot of capacity issues, and they needed someone to help follow through discharge planning home, right? And so they identified the patient based on their own risk scores and what they think was important. And we met with them on a regular basis as a team with their hospitalists and primary care operations and care coordination, and we said, what do we need to do to help these patients not come back? And so when Lake Forest identifies them, they notify our team, and our nurse actually has space in the hospital, and she comes to the bedside and meets the patient at the bedside and has a discussion with the inpatient nurse to talk about handoff and discharge plan home. That way the patient answers the phone, because they don't always know who's calling them, so they don't always answer. And there's a clear plan that the patient feels Northwestern's taking care of that patient all the way home. And then we do our work mostly telephonically. I say our work is 80% telephonic and 20% in person. We go to the patient's appointments, we can meet them in the hospital, we do some home visits depending on what the patient needs. That home assessment has a lot of value. And by doing this, we were able to help reduce the admissions of the multi-visit patient, this population, by 40%. And so it's been really impactful. We think the biggest win is working directly with the hospital operations team and being present so the patient can meet us before the patient gets discharged home. And so we've started this at NMH, and we're gonna scale this to Delnor. Now, if we can't actually be present because we're all busy and there's only so many of us, we do a phone call to the patient in the clinic, in their hospital bed, so that there's this warm introduction to our program, and patients are most likely to stay engaged with us thereafter. And again, we want to make sure our workflow is the workflow of our physicians, right? We are in Epic, we assign ourselves to the care team, we use message workflow the way they want it. We do not dictate workflow. We are the only system clinical team at Northwestern. Everything else is within the operating local units. We are a supporting team to patient care and to our physicians. That's how we see our work. And this is a case study that we all have heard about, but I just love how important, it highlights the importance of resources in patient care. We had a patient reach out to our PCP. He's been taking care of her for 20 odd years. Her mom died in Puerto Rico. She had to handle the estate, uncontrolled hemoglobin A1C of like 11 or 12, and had some problems with depression. She calls her PCP and says, listen, I have too much on my plate. My insulin's due. I have to refill it. I can't afford it. I don't know what to do. I feel the worst I've ever felt. And that was her message. And so he right away brought our nurse involved, who then right away got social work and pharmacy involved. And within 7 days, we got her 3 months of free insulin. We were able to get her access to behavioral health specialists and financial aid for her hospital bills. And she, of course, thinks the doctor's amazing, right? The doctor's the angel, saved her life, right? Yep, he's the best thing that ever happened. But we're okay with that. We're okay with it. We just see it is a privilege to support healthcare, right? And so our team is not feeling bad that Dr. Miller got all the praise, right? But the patient, though, feels like her world literally changed overnight. And I like to think of our work as like angels of healthcare. We're the last resort. And so the primary care practices before our team didn't have this resort. This patient would have gotten lost in messages. A medical assistant might have called somebody that might have known something that maybe helped her in 2 weeks. Then maybe she wouldn't have taken her insulin, or her depression would have been so bad she would have gone to the ED. So, this is simple, good healthcare, and we're very lucky that our team can be a part of it. The last thing I want to talk quickly is our operational. I showed you the numbers of our work, and we have a responsibility to stay lean. Stay lean. So one of our biggest struggles is patients aren't answering their phones. So I have nurses calling people, and the nurses are hating it, which I don't blame them. I would hate it. And it has been my focus to help this process. And so how do we get patients enrolled in a more efficient way so that people can do the work they need to do? So what we've done is we've partnered with a vendor up front. They're here today, good people. Nobody's been paid to talk about each other, so it's all good. But Upfront is actually going to provide us the service of doing this initial text to patients that will be customized to Northwestern standards. Introduce the nurse with a picture, introduce the program. Are you interested in having someone contact you that works with your PCP? The patient will say yes or no. If they say yes, we'll assign that patient to a nurse, and a nurse is calling a patient that's already ready to work with us. And we're very excited about this opportunity. We think we'll be able to greatly change the operational workflow of our nurse, which will improve our capacity to actually make an impact in patient care. So we believe that with this technology, we'll be able to, 25 to 40% increase the volume of patients we're actually supporting. And then the outcomes of utilization, improvement in hemoglobin A1C will follow. Thank you.
While we're getting slides up, I actually wanted to echo something that you brought up, Katie, and that's the accolades that Dr. Miller gets is only because you created a relationship with that patient. It's because you created a meaningful relationship with that patient and you showed value to that patient. And because you showed value to that patient actually connected the dots. Not only did you show value for that patient, you actually also showed value to the provider. And again, a lot of this is about physician engagement. All stakeholders have to see value in this care coordination process. So I'm going to be talking about something totally different than you guys have been talking about up to this point. Most of you come from fairly mature systems. You have risk-based contracts. I don't. I come from a small 2-hospital, nonprofit community system that has 15 primary care and specialty care clinics associated with it. We do not have any value-based contracts. We have all independent physicians. They all work independently and use the hospital system as their MSO. So again, we have the challenge of actually bringing these physicians into an environment which we know is changing, but they want to work as independent providers. So I'm actually going to be speaking from that lens and actually speaking about the challenges of physician engagement. But I think even though I'm different than a lot of you out in the audience, you actually, my message will resonate with you because physician engagement spans across all sectors. We have 30 primary care physicians. We have 20 advanced practice providers. And we see primarily fee-for-service Medicare. We have some managed care contracts as well as Medicaid or Medi-Cal in California. This is a very basic statement to put up a vision and a mission statement, but the reason why I put this up is because communicating who you are to people is incredibly important. And again, it's almost as fundamental as that, telling them who you are and what you're going to do. So right from the beginning, we created this and started to disseminate this information throughout our organization. People didn't even really know what the term care coordination was. Again, we have disparate physicians with disparate EHRs, and again, they've been running the show themselves with their nurse in the office. And so at this point, we needed to start introducing the concept of team-based care, introducing the concept of care coordination. So we also started messaging just with pamphlets. We started getting them out there both to the patients and to the providers. Again, when we were thinking about how we market, again, this term care coordination, we were not only engaging our patient population, but we were engaging our physicians, we were engaging our nurses, we were engaging our frontline staff. Again, it's as important to introduce this concept to the front office person as it is to the physician. And so when we started thinking about introducing this term care coordination, we actually took a marketing approach to it and started to sell the idea, if you will, and started to segment our population and our target population so that they could understand in their own terms what it meant to them. We started this whole process about 3 years ago. I became the Director of Population Health only 6 months ago, so again, we're really new. Our system is dipping their toe into population health. We're like a startup. That's what it feels like. We're having to prove ourselves along the way so that we, as we build capacity and as we try to scale some of our programs. We too have similar programs that Katie talked about. We have our high-risk case management. Again, we just have one RN and one licensed clinical social worker, but again, have showed remarkable improvements in again, the high touches and meeting them at the hospital and doing close follow-up and going to their office appointments and have had incredible reductions in hospital readmissions and again, patient satisfaction, physician satisfaction. We have a care management team that is actually payer agnostic, and that was really important to me. So even though we were going to try to leverage this value-based arrangement in the value-based programs with Medicare, we did have a payer agnostic process in that we were going to allow all of our patients, no matter what their payer was, to access care management. And again, we did that on a risk stratified basis, but we allowed any physician to refer any patient in. And I think that was very important because it's difficult for them to remember, does this insurance go here? Does that insurance go there? But we were accepting all referrals in. We have a chronic care management program. We have about 1,400 fee-for-service Medicare patients that are reached out to monthly telephonically from our nurses. And again, that's been very successful. You know, when we reach out telephonically, there's a learning curve for the patient, and there's trying to understand what is the value to that patient. Most of our processes, most of our care plans are patient-centered. And when I say patient-centered, we actually ask the patient, what is your goal? And that's what we're documenting, and actually that's what we're then communicating to the provider. So you have your medical care plan, but then we have this patient-driven care plan. And then actually we have, you know, a composite down at the bottom where we try to take the goals of the medical care plan and align them with the goals of the patient. But you will never move the needle forward if you're not aligning those goals with the patient. And we've been very successful in that, in doing that. We have a disease management program. We have about 500 patients with hemoglobin A1Cs greater than 9. I know that doesn't sound that exciting, but you know what? To us it is, because again, it's the first time for our health system that we've been able to take a cohort of patients and move the needle, and we've created workflows and processes around these. And we've been successful enough that we've been able to show our physicians, look at this is the value of a team-based approach. This is a value of protocol-driven approach. And we've actually been able to reduce our hemoglobin A1Cs by 2.3 points in this patient population over the last 6 months. It's better than drugs. Our annual wellness visits. So again, our annual wellness visits, we have a program dedicated to getting patients in for these annual wellness visits. Not only do we see the value as far as mitigating risk and understanding some of the social determinants of health and ADL assessment, we again had to educate our physicians about the importance of this, because when they're coming in for their diabetes or they're coming in for their COPD, a lot of times those types of issues aren't addressed, and this was a dedicated time for those issues to be addressed. We also tried to create some innovation within this and get our APPs to do days where they would see the annual wellness visits. Again, that helped decrease the burden on the providers as well as increase value to the patient. We just are launching a behavioral health integration program. We see over 300,000 visits at our clinic system a year, but we only had one psychiatrist. I just hired a psychologist several months ago, and we just applied for a grant from California State to hopefully build out our program around behavioral health. Again, it's a super important need. This slide is again, a slide you all could have in your own practice. Again, our Care Connections patient is in the middle, but for us, this is actually a novel idea. And I know it doesn't seem that exciting, but it's a really novel idea that the patient actually has all these wraparound resources. And again, communicating this idea and communicating the resources that we had available for our patients in the ambulatory setting. So we got pretty good at getting our patients to the emergency department or the outpatient radiology, but now we're really good at actually connecting that patient with a high-risk case manager, transitional care management, disease management, a Caregiver Navigator, which is actually a really unique program that we just got a grant for. Again, so it's a licensed clinical social worker that connects with the caregiver of the patient, because again, the caregiver being so integral to the health of the patient. So again, messaging to our providers that we have these services available in our ambulatory setting. These are some of the benefits of care coordination in our system. All of a sudden, we were taking away, as Katie said, taking away some of the burden off of the frontline staff in the offices. You know, if the patient was in the hospital, we're actually able to get those records now. Any patients that needed refills on medications, again, we are able to facilitate a lot of that for our patients that are enrolled. The most important one is the integrated bi-directional communication with PCPs. So we actually, we don't have fancy Epic, we have Allscripts, and Allscripts is not the best population health tool. But what we've done is we've made it work for us, and I think that that's very important. You've got to work with what you have, and what we have though is we have real-time communication with our providers, and so the providers now have come to understand that their patients that are enrolled in this program will actually be communicated with by our team, and we have very good bi-directional communication. They've come to trust the team. Again, the team has a lot of protocols so that they can facilitate care on their own, but the team typically reaches out when there is a patient need, and that patient need is taken care of right away. So the three things that I've learned in this past year or so is being innovative. Again, for us, because we're in a startup, everything's been innovative. Everything's been new. It's been new for our leadership. It's been new for our physicians. It's been new for our frontline staff. Again, what doesn't sound so innovative to you guys, it has been innovative to us, this concept of care coordination. And it's been exciting because it's really taken hold, and it's taken hold because we have quality people in place. Procuring data. So this has been a big challenge for us. We don't have fancy systems to cull data. We don't have a registry. So I've been using billing reports. I've been using any type of reporting that I can get so that I can make a business case to build my programs more. And again, it's been a big challenge. And then communicating your message to your target audience. We use a lot of our care managers, a lot of our care coordinators. We actually have them embedded in the clinics. We have them going out. We have them, targeting certain physicians that, again, may have patients that are going back and forth to the hospital. So they create a relationship with our care managers. So our care managers just aren't in, a building somewhere. Our care managers are actually embedded with our physicians in their practices, with their nurses, with their MA staff. They know all of their staff by name. And again, that too facilitates good care. This is some of the value-based program reports that I've culled across the organization, and again, it's not fancy, but it's doable. I just put this slide up there again. It's important when you're messaging. So I'm not only just messaging to the providers and the patients and the frontline staff. I'm actually messaging to our leadership as well. To our C-suite leadership, because they, as I said, they're sort of like, well, we know we've got to get involved in population health, but like, how involved do we have to get, and how much money is this going to cost us? And I'm not super excited about spending a whole lot of money on software or infrastructure, just sort of make it happen. So what we had to do was, again, look at our partners in the community and how can we leverage the data that they're collecting, and then look at our current state software. And what I can get out of it. And then again, current state software that we have that hasn't been leveraged, and then again, give them a roadmap for where I want to go next. So value-based care and provider physician engagement. This is from last summer. I climbed Mount Whitney, and this is what physician engagement, yeah. Oh, well. It's actually not that hard. It's just like a straight line up, and just take it slow.
Just 14,000.
Well, it's 14,505, I think. Yeah, let's get it right. It's a fabulous. If any of you like to climb, it's just a fabulous trip. But I like to, physician engagement is like climbing a mountain sometimes, and again, especially with a disparate group like we have, especially when you don't have any money tied to it. Again, trying to get them along a continuum is difficult. We became a level 3 PCMH about 5 years ago, and again, that was our first foray into transforming our organization. Again, it was sort of in name only, but we had to then set up a care management group to look at patients longitudinally, look at high-risk patients. The next thing we did was start to leverage our Medicare value-based programs. And again, that was going to be the carrot to sort of usher physicians along from that fee-for-service environment to the value-based environment. And we've actually done pretty well. It's actually allowed us to garner expertise in population health management, allowed us to, for each site to understand team-based approach. And as you see in a few of our programs here, our annual wellness visits, our chronic care management enrollment, and our advanced care planning, we year over year have actually been growing those programs. Our visit volume actually for our chronic care managements have gone from about 1,600 visits up to about 9,000 visits. And again, these are fee-for-service. And so, again, the physicians are realizing revenue, the patients are realizing benefit, and we're starting to move the needle. So then when we do get into a risk arrangement, we've learned how to, really connect with the patient. I always describe the patient, when we get a patient involved in chronic care management, the first day you call and they're not quite certain who you are, they think you're selling them something. The next time you call, they sort of vaguely remember that they had that interaction with you. And by the third time they call, they said, my nurse is calling me, and again, that's where you get to the Dr. Miller's such a great doctor. You build that relationship, and I think out of the one thing that I've heard actually at this meeting is creating that relationship. It can't be taken for granted because you create that relationship and it's like gold. That's your currency. This again shows, so we achieved over 64% of our eligible annual wellness visits, which I'm really proud of because again, our doctors didn't even know what an annual wellness visit was a couple of years ago. Reconciling quality metrics, again, this is a sort of another carrot with our pay for performance that we have. The physicians all of a sudden see that they have people that are helping them in this process, that they are actually helping them to reconcile their dashboards, and again, not only is it good patient care, but it's realizing revenue for them. I talked a little bit about our bi-directional communication. Again, it's embedded within our EHR. It's super helpful. We are able to facilitate care. And again, similar to what you were talking about, Katie, I mean, really meaningful care in dialogue with team members that they trust. So that's been nice. I think we're running out of time here. So that's the next mountain I'm climbing. And I hope your journey is not as arduous as this, but again, it's just one step at a time. So thank you so much. Okay. And we're going to take questions now, I think.
Yeah,
Do we have time? Oh,
yes,
barely.
we have a few minutes. We'll postpone our coffee for just a tad to get some questions in since we started late. My apologies to our exhibitors. That'll be my pitch. If you haven't talked to all the exhibitors and I'm cutting their time short, make sure you do it so we can get these questions in.
So I have a question for Katie from Northwestern.
Yeah.
You mentioned that one of the biggest barriers to good attendance show up at clinic visits was transportation.
Yep.
You mentioned we've done a number of things
Yep.
for transportation enhancement. Could you share those with us?
Yeah, so we have a contract with Kaizen Health, which is similar to a vendor, I think a program mentioned yesterday, I don't remember the name, so I apologize. But Kaizen Health is basically a service that connects the patient to whatever transportation needs they need. So it could be Uber, it could be an ambulance ride, or a Medicare, whatever the services they need to get to their appointments, whatever type of transportation, they would find the vendor, connect them to that transportation, send a text message that says, hey, we're here, and then we can close the loop. There's a cost that we incur, and so we're finalizing the policy for that, so we're not giving everybody free rides, because I think our team would love to give everybody free rides. But that's the service we're using as a system now. It started with local operating units, and now it's coming to the system.
So you pay for the liaison service and a portion of the transportation?
We actually pay for the transportation. So we have a contract that we pay for, and then we pay a reduced fare for the type of services that patient might need.
Thank you.
Yeah, it's called Kaizen Health.
Thank you very much for the presentation. A comment, really, then a question. Christine, thank you for sharing such a candid, open kind of journey through your process here. And I've been a part of practice transformation at various health systems at various stages of adopting something along the lines of value-based care delivery. It is blood, sweat, tears, frontline, just battles. So I applaud you. Congratulations on where you're going.
Thank you.
And good luck.
Thank you.
Hi, thank you for two very nice presentations. Yeah. This question's for Katie from Northwestern.
Yeah.
I've been looking at your slides again to kind of orient myself, but do you do anything differently in terms of your care management model for, I mean, I noted on your slide, but I don't know what it is, for the multiple frequently discharged and readmitted patients?
Yeah, so we focus on what the hospitals want us to focus on. So I think that might be a key strategy. We don't define populations at a system level, we define it by the local level within our system. So whatever the hospital wants us to support for them, we will then be their resource to help patients that are being discharged home to make sure discharge planning is followed through and make sure that they get to self-management and reduce barriers. So I think that is a unique strategy. We could very much say, anybody that has 3 or more admissions in 12 months, we're gonna support you at every hospital, but we let the hospitals tell us where their problem is, and then we support them there.
And that support is
Is our team.
Yeah, is it any different than the support you're giving your other?
No.
You don't call them more frequently
Nope.
or?
We just follow a standard operating procedure. It's just that's the way we get the patient that needs us, and then it impacts a system goal, right?
Okay.
And so
And have you followed those readmissions? I
Yeah,
mean, have you
they're-
seen a decline?
Yep. Decline for ED utilization and admissions. So it's working.
Okay, thank
I
you.
think the key is the local areas know what they need. And so we're actually able to make a more impressive impact by them telling us what they need instead of the system dictating this is how we're going to help high utilizers. Because every population is different. What Kishwaukee needs isn't the same as what NMH needs.
Right, so are any of your populations that you're
Mm-hmm.
helping out represent like a safety net population?
Yes.
And
Yes.
so do you do anything different for that population?
No, we identify that we very patient-centered. Whatever that patient needs to help get to self-management, we get the resources available, write goals, do the work we do.
Okay, thank you.
Yeah.
Fantastic job, ladies. Awesome. And I agree with your presentation, Christine, on getting to the community level. I'm sitting through this, the whole, Congress, just kind of listening. Wow, these people are doing some really fantastic, big kind of high-level programs, and it makes me feel like, oh, I have a lot of
No,
room
me too. I
lot of room to grow.
me too. It's been sort of that 30,000 degree, look at a lot of processes, and I'm thinking, oh, I'm so here.
Yeah, so, I mean, we all have to start somewhere, right? One of the things that I run into is we have all of these services that we want to wrap around our patients, and they get confused. Who is this? Who are you? You have home health coming in, you have everybody wanting to wrap around, and they get confused. How do you work through that?
So, we've had this issue, and again, they're telling you one thing in the hospital, and then you get out on day one and you get a call from 3 different types of, service providers. And so we've actually really honed in on that transitional care management piece and have a warm handoff from our from our care management team in-house to our outpatient team. So again, we're coordinating that line of care. We also understand who's been engaged from a home health standpoint of view. So again, we're able to message to the patient, you're going to be getting a call from this person. And it's been really helpful and useful because, again, if you have too many players in the pot, the patient's getting confused, they're not understanding what they're supposed to be doing, and again, it messes it all up.
Yeah. For us, we just focus on the primary care doc. So our team is just part of the primary care doc. It's all about the primary care doc.
Dr. Miller.
Dr. Miller. Who doesn't love Dr. Miller? He's an angel.
Well, he
Angel
sort of
boy,
is.
yep.
Yeah.
Isn't that so, though? What are universal themes that we're finding here, right? All the hard work we do, and it's that doctor that gets all the credit. But anyway, thank you for such
Thank you,
an
guys.
amazing presentation.